Good morning, everyone. So today we are going to talk about placenta, which is a very important topic in obstetrics. To introduce, I would also like to thank my head of the department, Uma ma'am, to introduce me so kindly and always showing faith for me. Thank you so much, ma'am. Welcome. So placenta in Latin actually is a word which means cake. It is a connecting stalk between the mother and the fetus, and during the brief but the very important intrauterine passage, the fetus is dependent on the placenta for pulmonary, hepatic, renal, circulatory and many other functions. Coming on to the gross anatomy of the placenta, human placenta is discoid, which pertains to its shape. It is hemochorial, that is, there is direct contact of the chorion with the maternal blood. It is deciduate because part of this maternal tissue is shed at the parturition. When you grossly observe the placenta, it is spongy circular disc. The diameter ranges from 15 to 20 centimeter, the mean being around 18.5 centimeter. The thickness is 23 millimeter. The weight of a term placenta is near 500 grams, and at term the baby's to placental weight ratio is 6:1. It occupies 30% of the uterine wall at term. Now, placenta has two surfaces. Fetal surface is smooth, glistening, and is covered by the amnion, which is reflected onto the core. You can see here, this is the fetus surface. This smooth, glistening membrane is covering it. This forms the 4/5 part of the placenta. The maternal surface, as you can see here, is dull greyish-red in color and is divided into 15 to 20 cotyledons. This maternal surface forms the 1/5 of the total placenta, and this is covered by a thin layer of decidua basalis. The grooves between these cotyledons are formed by the incomplete decidual septate. So how does this placenta develop? You know, as the ovum ovulates, and then within 12 to 24 hours, it meets the sperms, and this forms a fertilized embryo here. This fertilized embryo then duplicates its DNA in around 30 hours. This is a 2-cell stage where all the DNA material has been duplicated. This progresses to a multi-cell stage, which is known as morula. This happens around 3rd day. And then this morula converts into a blastocyst. Around this time only, this embryo actually travels to the endometrium cavity. Now this embryo is in endometrial cavity. This is 4.5 to 5th day. There is the blastocyst. This is the space containing, and here it actually adheres to the endometrial surface, then opposes and then invades. And that is how this fertilized embryo attaches to the endometrial lining. And this is how the future placenta will form at this interface between the embryo and the endometrium. So this is a detailed picture of certain stages only. This is the blastocyst stage. Here only the 5 embryo produce, these blue cells, the 5 embryo producing cells, these form the inner cell mass. The rest all cells, these 53 cells are destined to form the trophobacterioderm. That is similar to what happens at 107 cell stage. At this stage, the blastocyst is released from the zona pellucida, and secretory interleukin 1 alpha and 1 beta and HCP, they influence the endometrial receptivity. About this we'll talk later also. The endometrium itself produces LIF and CSF1. This increases the trophoblast protease production, and this leads to degradation of the selected endometrial extracellular matrix protein. And this is the first step of association between the endometrium and the trophoblast. So, as we have already said, implantation of blastocyst is divided into 3 phases. Apposition, which occurs from day 20 to day 24. Mind it, later on it is inhibited by anti-adhesive glycoprotein. So, this is a very short window period during which the embryo is to be implanted into the endometrium. Now, this addition happens through the integrins alpha 5, beta 3 and alpha 4, beta 1. These mediate the adhesion between the extracellular matrix proteins, and aberrant expression of these integrins on the endometrium actually may lead on to infertility. The step of invasion is totally controlled by trophoblasts because they invade into the endometrium, and that leads to the implantation of the embryo. Now, there are certain hormones also which prepare this endometrium. We know during the proliferative phase, there is from the Graafian follicle, there is increased estrogen. This leads to endometrial proliferation. Then progesterone leads to differentiation of this endometrium, which makes it conducive for the implantation of this embryo. Now, the blastocyst, when it has entered into the endometrial cavity and it rolls freely over the endometrium, it is rolling here. Then there are certain L-selectin ligands which are expressed by the endometrium. These actually they actually call the embryo towards themselves. There are also certain proteins known as mucin 1 these are on the that portions of the endometrium which are not conducive for the implantation. So they actually repel the blastocysts away from these places to the places where L-selectin ligands are expressed more. The place where the L-selectin ligands are expressed most are the places where actually the embryo implantation can happen very nicely. So there are also certain adhesion molecules, integrins and cathedrins. From here, the endometrial pinopods are expressed to ensure further successful implantation. So here you can see this is the day 9 implantation site. Here there are lacunae which are formed in the syncytial trophoblasts, and they are still to invade the maternal blood vessels. Day 12 implantation site. Here the lacunae have been filled by the blood coming from maternal blood vessels. So as we can see here, the spiral arteries are branching and filling this intervillous space with the blood. Here where all the nutrition will take place, and then the venous blood will be taken away from these spaces. The trophoblasts form a very important entity of placenta. They are divided into syncytiotrophoblasts and cytotrophoblasts. Cytotrophoblasts are again divided into villus trophoblasts and extravillus trophoblasts. Extravillus are again divided into interstitial and endovascular. Endovascular is that lining the vascular spaces, interstitial which forms the between spaces. There is also an important category of trophoblasts which goes by the name of intermediate trophoblasts. This is the distinct subtype of trophoblastic tissue that arise from the cytotrophoblasts, and it is categorized by the location. It is implantation site intermediate trophoblasts, villus intermediate trophoblasts, and chorionic type intermediate trophoblasts. Now this is a very important diagram. This shows the fetal maternal interface. This is the fetal interface and this is the maternal interface. Here the blood vessels are there on the maternal side, and this is the fetal anchoring villus. We can very well say this is the cytotrophoblast cells lining, and on top of there is without any cell boundaries syncytiotrophoblasts covering, and this forms these cytotrophoblasts actually proliferate, and here in the zone 2 they interact with the endometrium of the mother. And here the invasion starts. These form the intermediate trophoblasts, and this then goes into to line the blood vessels of the mother. So this is actually the fetal maternal interface. Coming on to the villi, we know the projection of the cytotrophoblasts when it happens, and there is only covering of the syncytiotrophoblasts. This is the primary villi. When there is extraembryonic mesenchyme present in between, this forms the secondary villi. Then when this is invaded by the blood vessels, this forms the tertiary villi. This is again the same picture. In the first trimester, we can see the villi is very nicely seen. You can see the blood vessels, the cytotrophoblasts. There is a surrounding layer of syncytiotrophoblasts. This later on, and during the 4th month, this cytotrophoblast has disappeared. There are numerous new blood vessels. These cells here are the macrophages. They also go by the name of Hofbauer cells. Then as the pregnancy progresses, this membrane has now become so thin. This is the placental barrier. This is the fetal blood vessels. This is the maternal space. This is intervillous space filled with the maternal blood. This yellow line is the fused basal membranes of fetal capillary and the syncytiotrophoblasts. And this is the less space through which the transfer of nutrients and other things can happen, and it becomes conducive for the baby to have all the nutrients. This is again the same picture. So the placenta, as we know, is limited internally by the amniotic membrane and the chorionic plate, externally by the basal plate, and in between these two lies the intervillous space. The functional unit of placenta is stem villi, and the truncal branch of chorionic artery supplies. There are around 60 stem villi, and which have the total surface area of 4 to 14 meters square. Okay, it's okay. So this is again the expanded diagram. Here you can see this is the fetal surface which is covered by amnion. This is the intervillous space, and you can see the spiral artery supplying it. Now decidua is also an important component. So decidua is actually divided into decidua basalis, the one part of the embryo, the decidua surrounding it where the future placenta is going to form is decidua basalis. The one covering the embryo is decidua capsularis. and the other, which is covering the other lining of the endometrium, is deciduoperitalis overa. This is the electron, beautiful electron micrograph picture of a 6-week embryo. We can very well see the embryo here, the umbilical cord, and this is the bushy chorion which is going to form the placenta. Now, how is the regulation of this trophoblast invasion happens? There are many things which actually promote the invasion, and then there is a check to it. So there are decidual natural killer cells which actually lack cytolytic activity. They secrete interleukin 8 and IIP10, which is interferon inducible protein 10. This promotes the trophoblast invasion, and this secretes the VEGF, that is vascular endothelial growth factor, and PLGF, placental growth factor. This promotes the angiogenesis. The integrin subunit expression, especially L-selectin, mediates adhesive interaction and scaffolding of the trophoblast and the decidual cells. Fetal fibronectin, which also goes by the name of trophoblastic glue, helps in this. So this is a picture. Actually, there are certain proteolytic enzymes which are secreted by the trophoblast, and this activates the proteinase and leads to digestion of the extracellular matrix. There are also urokinase type plasminogen activators which lead to the degradation of matrix proteinases and activation of MMPase. Then there is also IGF-2. Now decidual cells actually secrete a IGF binding protein 4, which will block this autocrine loop. So then certain places where the invasion has not to happen, decidual cells express these proteins which prevent this autocrine loop, and further invasion does not happen. The next step to study is feto-maternal circulation, which is again divided into two independent systems, that is uteroplacental circulation and fetoplacental circulation. In uteroplacental circulation, there is circulation of maternal blood through the intervillous space. So the total blood volume in placenta is around 500 ml. 150 ml is in the intervillous space and 350 ml is in the villus space. The intervillous blood flow is of the tune of 500 to 600 ml per minute. So these villi depend on the maternal blood for the nutrition. The pressure in the villi during uterine relaxation is, in this intervillous spaces, 10 to 15 millimeter of Hg during the relaxation and 30 to 50 during uterine contraction. The arterial circulation, 120 to 200 subspiral arteries open into the intervillous space by piercing the basal plate. Now pressure in these supplying arteries is way higher than the intervillous space even during the contraction, that is 70 to 80 millimeter of mercury. The venous drainage of the intervillous space drains through the uterine veins which pierce the basal plate again, and they have a very low pressure, lesser than the pressure in the intervillous space during the relaxation, that is 8 millimeter of the mercury. Now, fetoplacental circulation, we all know there are two umbilical arteries which carry the impure blood from the fetus, and then they enter the chorionic plate, each supplying one half of the placenta. Maternal and fetal blood flows side by side but in the opposite direction. Now, this countercurrent flow again facilitates the material exchange. The villus capillary pressure is of the tune of 20 to 40 millimeter of mercury, and fetal blood flow is around 400 ml per minute. This is again the diagram which shows the fetal circulation, and here we can see the spiral arteries piercing the chorionic plate, having the circulation here, and from here the two umbilical arteries. Actually, they are bringing the impure blood from the fetus. We already have studied about chorion, which is from the mother. The amnion part is the tough, tenacious but pliable part. This amnion is actually which provides all the tensile strength. It is avascular and it's divided into 5 layers. The first layer is single layer of cuboidal epithelium, then basal lamina, acellular compact layer, which is composed of again in collagen 1 and 3. This collagen is the one which imparts the maximum tensile strength. Then there is synergistic role of elastin microfibrils and decorins, amniotic mesenchyme fibroblast-like cells, and zona spongiosa. Amnion cells are derived from fetal ectoderm of embryonic disc. Amnion cells secrete MMP1, PGE2, fetal fibronectin, and they are involved in solute and water transport. They also maintain the amniotic fluid hemostasis. Now, there is a theory of induction of labor which is also associated with amnion, that in response to strength there is an alteration in the amniotic gene expression. This leads to various autocrine and paracrine loops activation and increased production of MMPs and interleukin 8 and collagenase. This leads to initiation of the labor. Amnion can also cause amniotic bands, and here you can see in long-standing oligohydramnios, it can have amnion nodosome. Coming on to the functions of placenta. Placenta has many functions. The important functions are the placental transfer function, which involve respiratory functions, nutritive functions, excretory function, production of certain enzymes. Placenta also forms a barrier, and it produces number of hormones and thus forms an endocrine function. So here it is the nutshell summary of the functions of placenta. We'll deal each function again. Placental transfer function. the factors which are responsible for a transfer of a substance across the placental membrane are its molecular weight. If it is more than 1000 Dalton, it is usually not transferred. Lipid soluble helps in transfer of the substance, while polar or ionized substance need carrier proteins. Area and functional integrity of placenta also determines how much substance transfer will happen, and rate of blood flow and concentration gradient. Now this is the placental barrier or the placental membrane. You can see here the maternal blood is flowing in the intervillous space. Then there is syncytiotriphoblast, cytotrophoblast, connective tissue stroma of villus, then endothelium and basement membrane and fetal blood vessels. What are the mechanism of transfer? The mechanism of transfer are simple diffusion along the concentration gradient, facilitated diffusion via the carrier, active transfer where it is against the concentration of gradient and we actually expend some ATPs or energies to do this type of transfer. Then there is endocytosis and exocytosis. So this is the active transport where actually various protein and here the ATP is being expended and the substance is being transferred to the fetal side. Now this is electron micrograph picture which shows the endocytosis. You can see here it is forming the coated pit here. This will endocytosis and now this is the endocytic vesicle being formed here. So this is the placental membrane again. Now what are the transfer function involved in? All the respiratory function, there is transfer of oxygen and carbon dioxide is mediated through simple transfusion. Excretory function, waste products like urea, uric acid and creatinine happen through simple diffusion. Glucose goes through facilitated diffusion, lipids, triglycerides and fatty acids by simple diffusion. Fetal fat, as you know, has a dual origin. In early pregnancy, mother is the only source for it, and in the later on pregnancy, the fetus synthesizes itself. Amino acids go by active transports, IgG across the placenta by endocytosis, water and electrolytes, sodium, potassium and chloride, simple diffusion, calcium, phosphorus and iron by active transport, water-soluble vitamins by active transports, fat-soluble vitamins by simple diffusion. Hormones like insulin, steroids, thyroid, chorionic gonadotropin or HPL cross at a very slow rate. Barrier function, the fetal blood in the chorionic villi is separated from the maternal blood in the intervillous spaces by the placental barrier, which is composed of endothelium of the fetal blood vessels, the villus stroma, the cytotrophoblast and the syncytiotriphoblast. Now we know there are certain substances which are regulated by their size itself. So the bigger molecules like heparin and insulin, they cannot cross the placental barriers. However, we all know that this barrier is actually an incomplete barrier because it is allowing certain substance to go through but not the other substances. So it can allow the passage of antibodies like IgG, hormones, antibiotics, sedatives and some viruses can cross the placental barrier like rubella and smallpox and also certain bacteria like Treponema pallidum. Now labeled maternal leukocytes and platelets can also cross the placenta and this is the basis of the genesis of erythroblastosis fetalis. This transfer can happen in countercurrent direction also, that is the fetal lymphocytes and CD34 plus mesenchymal stem cells also migrate towards the maternal side and they may go and reside in the maternal blood or bone marrow and by a phenomenon known as microchimerism they are actually hypothesized to cause autoimmune disorders in mothers later on like lymphocytic thyroiditis, scleroderma and SLE. Now, when we talk about barrier, we know this placenta is actually not totally safe for infection. So there are various infections which may be bacterial, viral or protozoal which can happen in placenta. They may be ascending infection that is through the vaginal route or from the maternal blood that is the transplacental route. So during infection, the placenta actually looks like this. There are actually cloudy and opaque chorionic plate and then you can see the infiltratory cells under the microscopes and chorionic vessels here are barely visible. So these are the various infections which are caused by the placenta and this is in listeria growth. And here you can see the CMV infection where it causes lymphoplasmacytic infection, stromal hemosiderin deposition, and there is mineralization, intranucleocytoplasmic bodies are formed. This is candidal infection. This is non-specific inflammation, chronic villitis. And as we talked about the inclusion body of CMV infection. In group B, beta hemolytic streptococci infection. There are also production of certain enzymes by the placenta, which are oxytocinase, monoamino oxidase, insulinase, histaminase, and heat-stable alkaline phosphatase. So the endocrine function, placenta actually secretes many hormones. The protein hormones are HCG, HPL, HCG, hypothalamic and pituitary-like hormones, and other hormones like inhibin, relaxins, and beta endorphins. Steroid hormones are estrogen and progesterone. Now, a brief word about HCG. It is a hormone secreted by the placenta. It has a non-specific alpha subunit, which is similar to LH, TSH, and FSH. It is a hormone-specific beta subunit. The half-life is around 24 hours. It can be detected in urine 8 to 9 days follows fertilization. Glycoprotein. It is a glycoprotein which is secreted by syncytial trophoblasts, and it reaches a peak on the 60th day of pregnancy. Later on, it reduces on the day 100 to 30,000, and then it is maintained so for the whole pregnancy. In early pregnancy, the doubling time of HCG is around 1.4 to 2 days, and this is very important differentiation between an ectopic pregnancy and a normal pregnancy. Alpha HCG in pregnancy roughly corresponds to the placental mass. We all know high levels of HCG indicate it might be in a multiple pregnancy, erythroblastosis fetalis, H-mole, Down syndrome, Turner syndrome, Klinefelter syndrome, trisomy 13 and 20. Lower levels of beta HCG are seen in ectopic pregnancy, early embryonic failure, trisomy 18 fetuses. And importance of beta HCG, it is very important hormone which helps in pregnancy tests and diagnosis of ectopic and follow-up of trophoblastic disease. The HCG actually rescues and maintains the corpus luteum till 6 weeks of pregnancy. HCG also plays an important role in stimulating the Leydig cells of the male testes to produce testosterone. It has immunosuppressive activities, and it stimulates both adrenal and placental steroidogenesis. It also stimulates maternal thyroid and promotes the release of relaxin secretion, and is hypothesized to cause uterine vascular vasodilatation and myometrial smooth muscle relaxation. Then now coming on to human placental lactogen, potent lactogenic and growth hormone like bioactivity glycoprotein. The major source is syncytial trophoblasts. It is also produced by invasive intermediate trophoblasts. Its level increase progressively until 36th week, where it reaches around to the tune of 5 to 15 microgram per ml. What are the functions of HPL? It causes lipolysis, and this increases in the levels of circulating free fatty acids, inhibits leptin. It also has a very potent anti-insulin action, which favors protein synthesis and provides a source of amino acids for fetus. Now, it is a potent angiogenic hormone also, which plays an important role in the formation of fetal vasculature. Chorionic adrenocorticotropin, which is very similar, it is also goes by the name of placental ACTH. It is not under the feedback control of glucocorticoids, and that is why mother has partial resistance to dexamethasone suppression during pregnancy. A cortisol positive feedback loop is formed with the placental CRH, and it is important in fetal lung maturation and plays a very important role in initiation of labor and timing of parturition. Relaxin is again a hormone which causes myometrium quiescence and relaxation, and so it's responsible for holding the pregnancy. It also causes the relaxation in various joints and ligaments during pregnancy, and also controls the postpartum regulation of extracellular matrix degradation. Now, there is a growth hormone variant which is also secreted by placenta. It goes by the name of IGF. It also inhibits the glucose in dose-dependent manner. Along with HPL, IGF causes insulin resistance. There are also hypothalamic-like releasing hormones secreted from the placenta, like gonadotropin-releasing hormone, corticotropin-releasing hormone, and growth hormone-releasing hormone. Activin and inhibin are also secreted by placenta, and inhibin actually decreases the FSH secretion and beta HCG synthesis, and it's increased in Down syndrome. Activin stimulates the trophoblast HCG secretion. There are certain cytokine-like growth factors like TGF-alpha and beta, EGF, IGF-1 and 2, atrial natriuretic peptide, neuropeptide Y, and leptin, which are secreted by the placenta. Now, this is a diagram which shows the various protein hormones level during the pregnancy. You can see HCG peaks around less than 10 weeks, and then the levels come down to 30,000, and then they are maintained like this throughout the pregnancy. While both HPL, CRH, they increase till the later part of the pregnancy. Coming on to the steroid hormone, the first important hormone which is secreted by the placenta is progesterone, and trophoblasts produce progesterone after 7 weeks and can maintain the progesterone level even after the removal of the ovaries or corpus luteum. So, rate of production at 12 weeks is around 25 nanogram per ml, but at the term it is 300 nanogram per ml. You know, the low levels of progesterone are seen in blighted ovum, abortion, and ectopic pregnancy, whereas the high level are seen in H-mole, RH, isoimmunization, and multiple pregnancy. After delivery, progesterone is not detectable in maternal bloodstream after 24 hours. What is the source of cholesterol for placental progesterone synthesis? Actually, the fetus is dependent on the mother for progesterone synthesis, where it utilizes the maternal LDL for synthesis of progesterone. During pregnancy, there is disproportionate increase in plasma concentration of 5-alpha dihydroprogesterone, which makes placental vessels resistant to presa agents, and this is excreted in urine as pregnanediol, and it provides a precursor for fetal adrenals to produce glucocorticoids and mineralocorticoids. Now here you can see the synthesis of progesterone is dependent on the maternal component. Here the acetate, which is synthesized into cholesterol, this LDL cholesterol, which will act as a substrate for the progesterone. This will lead to pregnenolone. Now this pregnenolone will migrate to the placental component, where the placental compartment will synthesize it into progesterone. Now the fetal compartment also has the LDL cholesterol, synthesis of LDL cholesterol happens, but it cannot synthesize the progesterone here. So it is the placenta actually which is involved in the synthesis of progesterone. The important point is that after the death of the fetus, even if there is a circulation in the placenta, the progesterone continues to be synthesized. So the holding of pregnancy can still happen. So there are, when in the intrauterine death of the baby, still the baby can be held because there is still the secretion of progesterone from the placenta. Whereas when we talk about the estrogen, it is produced mainly in the syncytial trophoblast, and conditions which are associated with low estriol, we all know it's fetal death, fetal anomalies, adrenal atrophy, anencephaly, Down syndrome, H-moles, placental sulfatase or aromatase deficiency, glucocorticoid steroid treatment, maternal adrenal dysfunction, maternal hypertensive disorders, and diabetes. So this is the hormone. It is dependent on DHEA in the placenta on subjection to enzymes like sulfatase and aromatase. Estriol and estradiol are secreted. Estradiol is again returned to the maternal circulation. So these are the levels of steroid hormones during pregnancy. Progesterone we can see actually peaks till the term. Estradiol, estrol, and estrone also increase till the term. This is again the placental estrogen synthesis. We'll skip this. Now there are certain pregnancy associated plasma proteins which go by the name of Papa A, B, C, and D, and they were isolated from the pregnancy serum in 1974. Papa B and C are pregnancy specific beta-1 glycoproteins. They are potent immunosuppressor of lymphocyte proliferation and prevents rejection of conceptors. Papa D and HPL, Papa D is also known by the name of HPL. A causes glycoprotein, and it's a glycoprotein which acts as an enzyme metallopeptidase. It cleaves insulin-like growth factor binding protein and thus increases the actions of IGF. Papa is also a marker of unstable angina and MI. There are still various research activities going with Papa proteins. Immunological functions of the placenta. Now, the fetus and placenta are actually contain paternally determined antigens also. In spite of this, there is no evidence of any graft rejection. So, exact mechanism of this is actually not known, but there are speculative various theories which have centered on placental hormones, proteins, early pregnancy factors, Papa A, steroids, which have got some immunosuppressive effects. Villus trophoblasts do not express HLA class 1 or class 2 molecule. Only extravillus trophoblasts express HLA class 1 molecules and no class 2 molecules. So this goes for the immunological neutrality of the trophoblast. There is also a shift of maternal response from cell-mediated to humoral, which may be beneficial to pregnancy. And HLA-G, which is expressed on the cytotrophoblast, is immunologically permissive of the maternal-fetal antigen mismatch. Decidual natural killer cells, as we have said, they are the peaceful model of trophoblast invasion and maternal remuscular modeling, where they actually do not have lost their cytophagic activity but secrete various substances which actually potentiate the invasion of the trophoblastic cells. Now, what is the role of placenta in labor? We know it is very important third stage of labor, where when after the delivery of the baby, we see how the placenta is separated by seeing the three signs: lengthening of the umbilical cord, suprapubic bulge, and gush of blood. And placenta actually after labor separates by two mechanisms. First is Duncan method, which is central separation, and another is Skurl's mechanism, where the separation happens. The Skurl separation is central separation, and the Duncan is the marginal separation. This is how after delivery the placenta is examined, where both the surfaces, fetal and maternal, are examined. You look for all the cotyledons or any missing cotyledon if present. If there is a leash of vessel which leads to a hole or gape into the membranes, you should actually look for another lobe of placenta. So a 1-minute examination of placenta is performed. You have to know the size, shape, consistency, completeness of the placenta, any SST lobes if present, infarcts, hemorrhage, tumor, and nodules. The umbilical cord is examined for its length, insertion, and number of vessels, knots, and membranes also examined for their luster, odor, and filamentous insertion. So these are certain specific examination you have to perform in pathological conditions. Retained placenta is not something we'll discuss here. The placenta may be abnormal in shape, That is, may have abnormal diameter, abnormal weight, abnormal position, or abnormal adhesion. This is how then we differentiate. In abnormal shape, the first category is placenta bilobata. Here what happens, there are two equal lobes which are actually connected by placental tissue here. Mind you, the word here is placental tissue. They are connected by the placental tissue. This type of placenta leads to increased chances of abruption, PPH, choriomnitis, and sometimes vasa previa also. What is the pathogenesis of bilobe placenta? It is said it is to arise due to implantation of areas of decreased uterine perfusion. So this decreased uterine perforation, actually where the perfusion is good, there the placenta grows very nicely, and where it is poor, the placental atrophy takes place. This is also known by the term trophotropism. So you have to examine the placenta carefully in placenta bilobate. Then there is placenta bipartite. In this, the placenta is again of two equal parts, but this is now connected by membrane. So there is leash of vessels. In one of the part of the placenta, the umbilical cord will be inserted, and there will be leash of vessels which will be connecting the two lobes. And rarely the umbilical cord also divides into two branches to supply each of the lobe. Now, when one of the lobe is very small, then it is placenta succinturata. So there is a larger lobe and then there is a smaller lobe, and there are connecting vessels. These vessels, when they lies over the internal os, they will give rise to vasa previa. Umbilical cord is inserted into the larger lobe, and it branches of its vessel across the membrane to the smaller lobe. The accessory lobe may be retained in the uterus after delivery, and this may lead to PPH. This should be suspected if a circular gap is detected in the membranes from which blood vessels pass toward the edge of the main placenta. Now, extracorporeal placenta also goes by the name of circumvallate placenta and circummarginate placenta. In circumvallate placenta, there is plication of the membranes. You can see here, there is a plication of the membranes evident as fibrin ridge across, which in the gross examination. In circummarginate placenta, there is no ridge here. Why does extracorporeal placenta happen? So it happens because of the marginal hemorrhage, which undermines the membrane and pushes them over to the chorionic plate. Another theory is there, when the embryo is not able to invade completely into the endometrium, it implants too superficially and then grows outward in a polypoid fashion, which can lead to placenta circumvallata. Now, this placenta can cause abortion, antepartum hemorrhage, preterm labor, IUDs, congenital anomalies, single umbilical arteries, and significant neonatal anemia also. This is how extracorporeal placenta will look like. This is the fibrin age, so this is placenta circumvallata. Now, abnormal diameter, very large placenta goes by the name of placenta membranacea. It may be as large as 30 to 40 centimeter in diameter, and the villi is destined to, which was destined to atrophy, becomes the chorion levae, are retained, while there is lack of growth of the villi, which is destined to become the chorion frondosum. So, abnormalities of the endometrium, such as endometrial hypoplasia, poor vascular supply of the decidua basalis, endometritis, multiple curatages, adenomyosis or atrophy of the endometrium may lead to the placenta membranacea. It may encroach onto the lower uterine segment because it has become so big, so it may cause placenta previa. It may also lead to premature delivery, placenta accreta, spontaneous abortion, and second trimester fetal demise. Another thing is placenta fenestrata, where a central area of the placenta is actually atrophied, which has sufficiently left only membrane. So you actually have to rule out a possibility of missing cotyledon in this, and this may be secondary to implantation over a fibroid or corneal tube orifice. So the part of the placenta which has implanted over the fibroid undergoes atrophy and gives rise to placenta fenestrata. Now there is zonal or annular placenta also, which has a ring shape, which is most likely derived from a placenta previa with focal atrophy of the low-lying villus tissue which cover the internal os. The tissue atrophy happens in the portion of ring giving the horseshoe shape. There is greater chance of APH and IUGR in these type of placenta. Placenta may be abnormally lodged in conditions such as congenital syphilis, hydrophytalis, diabetes mellitus, maternal or fetal anemia, or it may have an abnormal position. That is, like in placenta previa, when it is implanted in the lower uterine segment. We won't deal about placenta previa because it is a separate topic. There may be abnormal adhesion, then it gives rise to placenta accreta syndrome, which is again percreta, increta, and accreta. These are the things. There are certain circulatory disturbances which actually cause placental infarcts. So it is one of the most common placental lesions. 1/4 of the uncomplicated term placentas have infarcts. 2/3 of the hypertensive pregnancies have placental infarcts. So this results from the occlusion of the maternal vascular supply, that is the intervillous circulation. When you see histopathologically, it will be there will be fibrinoid degeneration of the trophoblast, calcification and ischemic infarction from the occlusion of spiral arteries. What are the etiologies which cause this infarcts? It is associated with placental aging, impairment of the uteroplacental circulation, which is seen mostly in thrombophilias and hypertensive pregnancies, marginal infarcts and subchorionic infarction. Now, infarcts are of two types, red infarcts and white infarcts. Red infarcts are fresh infarcts due to hemorrhage from the maternal vessels into the decidua. All red infarcts will, due course, due to deposition of fibrin, will become into white infarcts. And this may be also due to deposition of calcium. You can see the white infarcts here and the red infarct here. There is villus artery thrombosis. When there is occlusion of single fetal artery, it will deprive only 5% of the villi of their blood supply. In general, it may have little clinical significance, but it is postulated to cause IUGR and IUD if happens in large amount. So these are the various thrombohematomas. We know retroplacental hemorrhage, which happens behind the placenta, intravillous thrombohematoma, then subchorial thrombosis and subamniotic hematoma. And then there is marginal hematoma. Placental abrasion happens due to this formation of retroplacental clots. This is again a separate topic which you know. Coming on to the Granum grading of placenta, which tells about the age of placenta when you look on the placenta through the ultrasound. So grade 0 is given when placental body is homogeneous, the amniochorionic plate is even throughout, and it's seen in the late first trimester and early second trimester. Grade 1 is when placental body shows a few echogenic densities which are ranging from 2 to 4 mm in diameter. Chorionic plate shows small indentation mid-second trimester, early third trimester it happens. Grade 2, when the chorionic plate shows marked indentation which creates a comma-like densities which extend into the placental substances but do not reach the basal plate. The echogenic densities within the placenta also increase in size and number. The basal layer now comes to become punctated with linear echos which are enlarged with their long axis parallel to the basal layer. In the late third, it is seen in the late third trimester. Grade 3 is the completely mature placenta which is seen in the postdatism or after around 39 weeks. Here the complete indentation of the chorionic plate through to the basilar plate happens, which creates the cotyledon. Circulation of placenta is very important, where we have to give a special mention in PIH. In PIH actually there is absent of secondary invasion of trophoblast at around 12 to 16 weeks. So there is absent conversion of the spiral arteries into wide bore capacitance vessels, and this leads to placental insufficiency, endothelial dysfunction and PIH, pregnancy-induced hypertension. So something is after second wave of trophoblastic invasion which has to happen like this, that increased maternal blood flow where the endothelium will be replaced by the trophoblast. This does not happen and this remains contracted, so there is impedance to the maternal blood flow. These are the other complications of PIH which we not deal. Special mention of placenta in diabetes. In diabetes, normally also HPL and we know IGF actually have anti-insulin-like factor. There is increase in insulin and this increases the fetal aerobic metabolism, increase in oxygen demand. This may lead to hypoxia again, then again hyperplacentation can happen. In IUGR, we know there is impedance to the flow of maternal blood, or there are other factors which will lead to reduced blood supply to the baby and hence less growth of the baby. And this actually is the result of various pathology rather than a condition by itself. In thrombophilias, we actually have perivillous fibrinoid deposition, subchorionic fibrinoid plaques, massive subchorial thrombosis, syncytial knots, intervillous. All these processes lead down to reduced supply to the fetus, resulting in IUGR and later on to the IUD. Placenta also plays an important role in preterm birth. There are various factors which lead to activation of the parturition, and there are anatomic abnormalities such as battledore placenta, circumvallate placenta and marginal insertion through which also preterm birth can happen. Now there are certain placental tumors which goes by the name of gestational trophoblastic disease. This is a separate entity, but that happens due to abnormal proliferation of the trophoblastic tissues. In syphilis, we can know the placenta is grossly large, bulky and pale. It is increased. There is increased lymphocytic inflammatory infiltration of villi. The umbilical cord. It is very important to study umbilical cord with this also. We all know it develops from the connecting stalk, and at term it measures around 50 centimeter. The diameter is around 2 centimeter. This is the 3-vessel umbilical cord. Note, we can see here there are 2 arteries towards the right and a single vein at the left. vein is smaller in color, or arteries are prominent muscularis layer, and this is the Wharton jelly which actually suspends all these three. Now we know it is not a central incision but eccentric insertion 70% of the time. Central incision can happen 30% of the time. If the placenta inserts at the, if the umbilical cord is inserted at the margin of the placenta, it is known as marginal insertion. Abnormalities in the umbilical cord this is the marginal insertion, which also goes by the name of battledore placenta, or it may insert into the membranes, and there is a leash of vessels which go towards the placenta, and this leash of vessels, when they lie over the internal os, can give rise to vasa previa. This is velamentous incision of the cord. Vasa previa, we all know, is a very dangerous condition because any bleeding may lead to fetal exsanguination very fast. What are the complications of marginal incision? It may lead to IUGR, preterm labor, and it is actually also of dynamic placentation of trophotropism, where the placenta may atrophy on one side and expand onto the other side where there is better supply, and thus this leads to marginal insertion of the umbilical cord. Abnormal length of the umbilical cord. Long cord may also lead to cord prolapse or coiling of the cord around the neck, and there may be true knots of the cord. Short cord may lead to intrapartum hemorrhage due to premature separation of the placenta and delayed descent of the fetus during labor, and inversion of uterus can also be caused. Now coming on to the knots of the cord, there is a true knot when the fetus passes through a loop of the cord, and if pulled tight, true knot can cause fetal asphyxia. There is a false knot which is formed due to heaping of the Wharton jelly, as we can see here in this picture. This is the false knot. It is non-symptomatic. This is the true knot. This can lead to fetal IUD also and fetal asphyxia. There is also torsion of cord, and this happens when the Wharton jelly is less abundant. Hematoma. This all leads to morbidity of the fetus. The single umbilical artery, which is associated with other fetal congenital anomalies. Coiling was also known to be causing various effects. When there is more coiling or less coiling, it is associated with fetal demise or IUGR. There are certain procedures also. We'll skip these procedures. Then coming on to the tumors of the placenta, it is chorioangioma, most common placental tumor, benign hemangiomas of the fetal blood vessels, 1% of the placenta. When more than 5 cm in diameter, the complication can be polyhydramnios, preterm labor, APH, IUD, and fetal malformation. This is chorioangioma of tumor of the placenta. There may be metastasis of malignant tumors to placenta. And that is all about my lecture. Placenta is the first dialogue a mother has with her baby, and it represents the selfless love with which the mother nurtures her baby and prepares the baby for an earthly journey. Thank you so much.